Hi, my name is Fiorella Jarrin, and I'm going to talk about Isoniazid preventive therapy in HIV-infected pregnant and postpartum women. Definition: tuberculosis is the leading cause of health and death among persons with HIV infection who reside in low-income and middle-income countries with high tuberculosis burden. Among women, tuberculosis predominantly affects those of reproductive age. When tuberculosis develops during pregnancy or the early postpartum period, it is associated with adverse maternal, pregnancy, and infant outcomes.
If you have HIV/AIDS and find out you are pregnant or think you may be pregnant, you should let your healthcare provider know as soon as possible.
Some HIV/AIDS medicines may harm your baby. Your healthcare provider may want you to take different medicines or change the doses. It is also possible to give HIV to your baby. This is most likely to happen around the time you give birth. For this reason, treatment during this time is very important for protecting your baby from infection. Several treatments may prevent the virus from spreading from you to your baby. Your healthcare provider can recommend the best one for you. Your baby will also need to have treatment for at least the first 6 weeks of life. Regular testing will be needed to find out if your baby is infected.
Application in nursing. In the multicenter, double-blind, placebo-controlled, non-inferiority trial, we randomly assigned pregnant women with HIV infection to receive isoniazid preventive therapy for 28 weeks, initiate either during pregnancy or at week 12 after delivery, the first group.
One of the emerging themes that have come out in the last year and has been very strongly articulated in CROI this year is the need to get data, efficacy and safety data in pregnant women, and to have it in a timely manner. And this has been a long-standing problem that women are viewed as a vulnerable group and end up being a neglected population in terms of getting the requisite evidence to treat safely and effectively. So we have shown that in a certain group of women at high risk of transmission, that dolutegravir could potentially reduce the viral load much faster than current standard of care. Now, over the last year, dolutegravir has had a bit of a mixed press. It's certainly a very effective drug. It's certainly been rolled out across the globe. But there have been some alerts around the potential for birth defects, neural tube defects, although these are yet unconfirmed and preliminary. However, the response to this concern has very understandably been heightened by the report, and so different countries have implemented different things. There are countries who say we can use dolutegravir freely in pregnancy outside of the first trimester, which is when all the risk of neural tube defects is, ranging right across the countries which have said no dolutegravir to any woman of childbearing age whatsoever. So I think we are arguing for a much more appropriate, stratified, risk-based approach to taking dolutegravir. And in the third trimester, where the organs have already formed, there is very little risk of congenital malformation and a lot of benefit potentially from the rapid viral load reduction.
Pros and cons. Pros. Isoniazid in addition to ART is strongly recommended for the prevention of tuberculosis in patients with HIV infection. Cons. The safety and efficacy data are lacking regarding isoniazid preventive therapy in pregnant women who are receiving antiretroviral therapy because pregnant women have been consistently excluded from trials of isoniazid preventive therapy.
Antiretroviral medications are used to prevent the perinatal transmission of HIV from an infected mother to her baby, but this benefit needs to be weighed against the potential toxicity and adverse pregnancy outcomes associated with combination antiretroviral therapy. The PROMISE trial enrolled 3,529 women in the second trimester of pregnancy who had asymptomatic HIV infection with a CD4 count of 350 or more and randomized them to one of three groups. The zidovudine alone group received zidovudine during pregnancy, a single dose of nevirapine intrapartum, and tenofovir M-tricytidine postpartum. The zidovudine ART group received combination zidovudine, lamivudine, lopinavir, ritonavir during pregnancy and postpartum. And the tenofovir ART group received combination tenofovir, M-tricytidine, lopinavir, ritonavir during pregnancy and postpartum. Rates of discontinuation due to toxicity were low across all groups. The primary outcome was the percentage of neonatal HIV infections measured 1 week postpartum. An interim analysis of the study demonstrated that the rate of early transmission of HIV was 1.8% in the zidovudine alone group, as compared with 0.5% in the combined zidovudine ART group and 0.6% in the tenofovir ART group, both significantly lower than in the zidovudine alone group. However, the zidovudine ART and tenofovir ART groups had higher rates of maternal chemical abnormalities than the zidovudine alone group. Zidovudine ART and tenofovir ART were also associated with more adverse pregnancy outcomes, such as low birth weight and preterm delivery. The authors conclude that combination antenatal ART resulted in significantly lower early HIV transmission than zidovudine alone, but at higher risk of adverse maternal and neonatal outcomes. Full trial results are available at nejm.org.
Issues applied in Ecuador. In Ecuador, the MSP has arranged for the diagnosis of HIV infection in pregnant women in all public sector health units that have a laboratory and in some self-employed. All pregnant women with a cough lasting 2 to 3 weeks should be considered respiratory symptoms and therefore should be screened for active tuberculosis. Conclusion. The risk associated with initiation of isoniazid preventive therapy during pregnancy appear to be greater than those associated with initiation of therapy during the postpartum period. Thank you for watching.